Ladies and gentlemen, this is just the right time to begin our sessions. This one is the plenary sessions that we are very fortunate and very honored to have the Professor Dr. Dale Fisher, who's the plenary speaker for this session this morning. And the topic for today allowed me to announce that again. It's about the research as a core pillar of the outbreak response. Professor Dale Fisher is from the National University Hospital, U Long Lin School of Medicine, National University of Singapore, or we call it in short as in US from the Singapore. Professor Dale Fisher is an Australian infectious disease physician who first moved to the National University Hospital, Singapore in March 2003. And during the SARS outbreak, I think that everyone have heard about the SARS outbreak during those years. And he has had many leadership roles in the international outbreak commissions. In Singapore, he is the group chief of the medicine at the National University Health Systems, and also lead many efforts to the Ministry of Health, including chairing the National Infection Prevention and Control Committee. He is the chair of the steering committee of the WHO's Global Outbreak Alert and Response Network. Additionally, ladies and gentlemen, he has supported many whose WHO guideline efforts and was one of the 12 international technical experts who visited China in February 2020, which is the time that we have the COVID-19. And to investigate the COVID-19 outbreaks in China, he has authored around 200 peer-reviewed publications and also given over 100 invited and plenary presentations at international conferences. He recently was awarded Singapore's National Outstanding Clinician Award 2021. Okay, at this time, I would like everyone, ladies and gentlemen, to welcome the plenary speaker, Professor Dale Fisher. Professor Dale Fisher, the floor is yours. I couldn't hear you, Professor Dale. You are on mute. Thank you.
Yeah, the old mute trap. Can I just confirm you can hear me okay and that my slide is on full screen?
Sure, full screen, and we can hear you well.
Okay, great.
We have you have time about 30 minutes, Professor Dale. More or less.
I can do that.
Okay.
So firstly, thanks so much for inviting me. I think Kanda did the hard yards, and but being invited to the Lancet University annual conference on research is more of an honour than you know. So I'm going to spend the next 30 minutes really talking about how the importance of research in outbreak response. You're probably not going to learn a lot, but I think it might help you sort of crystallize how it fits in and how it can be best enabled. And firstly, just to point out that the response which sits down there in the box at 6 o'clock is really part of a cycle. And I don't think a lot of people appreciate this, that we're now currently at the tail end of the response, we hope. And this will go into a mode where where health systems have to recover, where there'll be a lot of after-action reviews and reflections on how we went in national and subnational levels and institutional levels, and these reviews and lessons learned, if you like, will feed into future preparedness efforts, and then all these peacetime efforts about preparedness really. For the COVID example, they all stopped on December 31 because that's when we went into readiness mode. We could see what was coming, and it was time to really have a mindset shift into where the response was going to go. And then, of course, by February and March, most of us were getting very heavily involved in the response. The reason I'm showing this slide is just to say that research is not divorced from these efforts. While the after-action reviews are a form of research, research into preparedness activities and understanding the research and the lessons learnt to better prepare for the next outbreak is important. Likewise in readiness, but the focus of this talk is obviously on outbreak response research. Now, I just want to take you back to the oldest photo I can find, which describes the core pillars, and this was given to me by a friend from an African outbreak responder friend of mine. And you can see here's all the contact tracers here and doctors here. And I want you just to focus on this little chart in the middle. And as you zoom in there, it was my friend that put together this chart saying, look, this is how you do a response. You know, there's case management, there's laboratory, what they called social mobilization at the time, and surveillance and epidemiology. And this all has to be coordinated and logistics. And depending on where you are, you've got all these ones around the outside which make that happen. And over the last 20 years, really, this has morphed into a different chart. This is, I've just used as a backdrop one of the foreign worker dormitories because in Singapore, because as you know, we had a lot of transmission there in around May, June, July in the first year of the pandemic. And what we did there was apply those same pillars, albeit modified. And this is probably where we sit now, that there's case management, laboratory, epidemiology, surveillance, IPC, logistics, maintenance of essential services, and mainly health services in this perspective, risk communications, community engagement, and wellbeing and psychosocial support. And I don't think anyone would argue that these are a way of dissecting out an outbreak response. And what I'd like to show you is that this is where research fits in, that I will show you some examples of research in each of these fields and how it's enabled and supported the response. Now, often these are done by public health agencies. So the Robert Koch Institute here, China CDC, which is actually where we went in February 2020, was one of our destinations where we met people and had a look at all the data and the research they were doing. This is the National Centre for Infectious Disease in Singapore, who's done a tremendous amount of research, particularly operational research and research that sort of really matters at the, really downstream research. And of course, US CDC and Public Health England. And this was one of the very early outcomes from the Chinese CDC, where it was just so important. I don't know if you remember the hunger for for this information. This is February 2020, and we wanted to understand, how it was transmitted, what the features were, and does it cause diarrhea or not, and all these types of things we were trying to understand. And then of course US CDC produced a nice one, and this is January to April 2021. So you remember the vaccine campaign started in around December 2020. So the CDC, because of their data management, was able to share this piece of research that actually breakthroughs were happening in people that were vaccinated. And as we know now, it's very, very common knowledge that the vaccine strength is in severe disease rather than stopping mild and asymptomatic disease. And this is a nice one that came out of Singapore as well, also describing the epidemiologic features and clinical course of local infections. So these are the types of things that big public health agencies do and should do during a response. They should also drive a lot of preparedness and readiness activities, of course. At the more sort of global level, the WHO established this R&D blueprint group. I think it started around 2015, 2016 in the wake of the West African Ebola events. and you can see that this is really core business and well linked with the emergencies program of WHE within WHO, and you can just read through some of the mandates there, but it really got a good shot in the arm at the beginning of the COVID response. It was clear that they needed to be nimble with supporting and funding and encouraging collaborations. And there was a meeting that it was I couldn't make it. It was just before we left for China, but there was a meeting there to prioritize what would be important information, and this is back in February 2020. So this is when people say what was WHO doing, that they were doing a lot, and this was the research side of things, which is probably I guess underappreciated globally, but they wanted to accelerate the innovative research and as well as that support research priorities that could contribute to the global response. This is one of the first pieces of research they put out that was heavily driven by them, which was in the end of the Ebola outbreak in Guinea in 2015. They took on 90 clusters. It was about 70,000 contacts and contacts of contacts. There's not the resources to just do mass vaccination as we've seen with COVID, but they were able to do a randomized control or cluster controlled study to actually prove that the Ebola vaccine worked. And the control arm was actually not giving it to contacts for 21 days versus the active arm, which was giving it to people as soon as they were recognized. So everyone got the vaccine. It was about the timing, and it was cluster controlled so that you wouldn't be sort of comparing with your next door neighbor. It was everyone in that same cluster would either get the vaccine immediately or 21 days later. So this was really some hallmark work that has really changed the face of how we manage Ebola outbreaks in West Africa. And you've noticed, despite there being probably one a year since then, they've all really been limited to double figures. Other big international projects, I'm sure you're all very familiar with the recovery work, which is randomized evaluation of COVID-19 therapy. This was extremely novel research. This was extremely novel research because what they did was have it was rolling, and it would work. It could be applied to all number of therapeutics. And people could come in and out of the trial, or institutions could come in and out of the trial from quite a number of countries. And they could, for instance, they could share placebo arms, which meant you could get through studies faster rather than every drug had to have its own placebo arm. And you can see the number of drugs that they've been responsible for looking at through this time. And it's just an extraordinary global effort, global collaboration. The Global Outbreak Alert Response Network is a network, a WHO network of 270 partners across the world. These are big humanitarian groups, UNICEF, IFRC, non-government organizations such as MSF, all the public health institutions, CDC, everything, Africa, China, US, Nigeria, all in it, but also a lot of academic institutions that are involved in doing research that could be useful in outbreak response. And while outbreak response is its primary reason for being, in 2014, actually during the Ebola outbreak of 2014-15, we sort of realigned ourselves that deployments were no longer about just sending someone or putting a bum on a seat. It was about improving the quality of outbreak response. So the point is, this is less than 10 years we've really been prioritizing research in outbreak response. So you can see this was going to be our approach going forward in a summary, and you can see here operational research and tools to developing tools for operations. was going to be key. And this also got a shot in the arm during COVID, where we could help partners attract funding. We could help with access to countries. We could help collaborations. We could call some large meetings and basically stimulate a lot of this through Goan's efforts. And moving a little bit downstream from that, we also, quite by coincidence, had arranged through Biomed Central, the journal BMC, that we would have an outbreak response series. So we were founded in the year 2000. So in 2020, we had planned to do this series, and we've ended up with 50 or 60 specific publications in BMC. As I say, it wasn't supposed to be part of the pandemic, but basically the opening of this, which took about a year to get started, but the opening of this was, I think, January 2020. So we've done quite a lot of work through this sort of Goan sponsored research into BMC. One of the earliest things I realized, which was one of the earliest publications in BMC, was just the remarkable speed, volume, the free access to information that was coming out in journals that you'd otherwise have to pay for. You know, the preprint manuscripts, rapid publications, opinion pieces. You know, that they were all essential. They were all pouring out. But as you know, we got into you know, issues really quickly surfaced that a lot of these things were a lot of these shortcuts, if you like, to publication were having implications. And of course, this was one of the first ones in Lancet, where hydroxychloroquine or chloroquine, with or without a macrolide, a multinational registry analysis. Now, this was describing about 96,000 hospitalized patients, and almost 15,000 people had received one of these combinations. And they said, we were unable to confirm the efficacy, but each of these drug regimens was associated with decreased in-hospital survival and an increased incidence of ventricular arrhythmias. Now, this is information we sort of wanted to hear, we believed in, so I think Lancet was very quick to grab it, but it was also just a couple of weeks later that the authors had to put in a retraction, and Richard Horton, I remember, was horrified that because when as due diligence they sent in some peer reviewers, they actually could not find the raw data. The implication being that the authors may have been legitimate, but whoever fed the it simply couldn't be validated, which therefore means it doesn't exist, which therefore was a lot of egg on the face of Lancet, and this had to be a retraction. Another one was an interesting one, also New England Journal this time, transmission of COVID-19, asymptomatic transmission. You remember in January and early February we were saying, is this a thing? Because it had huge implications, and even in China we debated this a lot. Is this a concern? Because it really drove whether we had to wear masks in normal circumstances. Now I'll tell you, this letter was published on the 28th of January, and the index case tested positive on the 28th of January, 2 days earlier. So they quickly pushed this, saying, oh, this woman was traveling after a business meeting in China. She came back to Germany. She had no symptoms, and this proves asymptomatic transmission because some of the contacts subsequently developed COVID. But actually, when someone went and spoke to her, they said, she said, actually, I did have symptoms. I just didn't tell anyone because I wanted to fly back, and I even took some paracetamol. So again, it was something we sort of really wanted to know, really wanted to believe. Someone wanted to publish it, but the information was flawed, and this really created damage early on. I mean, we can understand it as scientists, but how does the media and lay people get around this? You know, what do you believe? It was just happening too fast. This was another disappointing study. I remember this was this research never really had a good chance because they were because it was an intravenous therapy. They were only giving it to people that were sick enough to be in hospital, and we know that the viral shedding is actually very early. And these people were like day 6 or 7 by the time they were getting admitted, when most of the damage had been done, and using an antiviral at that stage. And we know this in treating, you know, herpes simplex or chickenpox or anything. If you're going to treat it, the advantage is treating early. So this, of course, was failed. This showed no benefit, but it wasn't long before things settled down, I think, and we started to get some great work, the dexamethasone work from Peter Horby and others in Oxford leading that, showing the great decrease in mortality from people requiring oxygen with dexamethasone. And then, of course, the Pine Tree study, which confirmed what we had hoped, which was that early remdesivir to prevent progression would work. And that was, again, a bit more pragmatic, because we weren't treating the situation. We were treating, we were testing the more likely science. So they're just some examples of case management. Of course, there's a lot of clinical trials and things that you could read about, or even basic science. In laboratory, I'll just give a couple of examples that, you know, there was a lot of work done around the antigen rapid tests. And this was a meta-analysis looking at them all. And what they showed was that the vast majority were very useful at detecting SARS-CoV-2, especially in the first week of symptoms, and especially in those with a high viral load. So this actually made it a particularly valuable test. And I think now, because of the research that was done into that, we're all quite comfortable with rapid tests. We know it's not as sensitive as PCR, but there's certainly value and a lot of advantages. In Singapore, we took that and described an implementation of it, taking the knowledge that they work, and we were routinely testing all healthcare workers twice a week. Twice a week, and what we found was that we'd done 156,000 tests and identified 20 staff that were true positives. There were about 11 false positives found on subsequent rapid testing and PCR, but finding those 20 people, it's not without cost, obviously, when you have to do so many, but the implications of 20 staff over the course of a month or two not being identified, and the spread to other patients, the spread to colleagues, and therefore the absence from work, this was all something that this implementation was going to help. So infection control, I mentioned before, the viral shedding, and this was critical information early on. In fact, we were getting this information in China in February 2020, just before it was published. But you can see here, as opposed to SARS-1, where the viral shedding was late, which means it's much more of a nosocomial infection, you can see here that the CT values are much lower early on in the illness, and it also raised a lot of questions over pre-symptomatic transfer, because it had to get up to there by day 1 of illness. So this was very important in how we would define our infection control. There's a lot of infection control papers, whether it's on masks or aerosols or whatever here, and I'll take the liberty. This was the first study on the Pfizer vaccine, which is infection control. You could also argue it's case management, but nonetheless, this was some of the work on that we were hungry for vaccines. And then, of course, in the post-marketing surveillance, we had to deal with all the discussions around anaphylaxis and carditis. And this is another study. We did a meta-analysis of all the studies on myopericarditis in vaccinations and found that overall myopericarditis occurred in vaccinations and obviously occurred in the COVID vaccination, but the risk was really in the under 30-year-old males. The risk was higher in those having an mRNA vaccine, and the risk was higher in those having a second dose. So that was looking at 22 studies and 395 million COVID doses. So this was a lovely analysis that was just recently published. Moving along to logistics, you think, what does logistics research look like? We can see that just the highlighted bit, that it's another frenzy of research, if you like, that 84% of research into supply chains had occurred in the first 10 months of 2020. So, and research used to be about healthcare and flu, but now it's much more about food supplies and things like that. And they're using more methods such as simulation, modeling, and empirical methods. So there is even research into logistics and even into leadership and coordination. I'll just accelerate a little bit because of time, but this is one that looked at Twitter and how they discussed how that analysed national messages and things like that. Particularly interested in political, socio-economic, and population-based issues. And the next paper I saw was health policy and leadership models during the COVID-19 pandemic. So that was looking at various models, compartmentalizing various aspects of leadership, and finally this was another one done out of Indonesia, actually, and describing how communication was actually one of the most important features of good leadership. So there's research in leadership as well. Well-being and psychosocial support. This is the risks of mental health outcomes in people with COVID-19, showing that they looked at 150,000 veterans and had about 10 million controls of various sorts, and found an increased risk of anxiety disorders, depressive disorders, stress and adjustment disorders, and use of antidepressants, benzodiazepines. So these are survivors of COVID having mental health disorders over and above the disorders that might be seen after other medical problems. Here's a study looking at how the economic slowdown related to COVID caused mental health issues. Sorry, is that? Yeah. And another one here on the effect of quarantine, and they looked at 24 papers and found a lot of stressors, which were longer quarantine durations, fears of getting infection, frustration, boredom, inadequate supplies, inadequate information, financial loss, stigma, lots of psychological impact. So again, the need for research doesn't stop anywhere. And I thought I'd stop showing more papers, but you can see that these are things that we know, that we had problems with dental care in our foreign worker dormitories because they were all locked in. Cancer screening fell away, malaria control programs, TB programs, routine vaccination, polio eradication program has taken a hit. Cardiac interventions and cardiac disease has all increased. All elective surgery, of course, took a hit, and excess mortality beyond COVID reflects this, that people were dying of other things, not just COVID. So many publications on maintenance of essential health services. Epidemiology and surveillance, well, I've already shown you several of those. There's whether it's in epidemiology, transmission, contact tracing apps. There's just so much research done in these areas. This is probably one of the most remarkable ones to me, because this was the one from Singapore that absolutely proved 10 cases of asymptomatic transmission amongst a number of clusters early on in our outbreak in Singapore, and it was in the wake of this that we mandated masks for all people. Up until then, it was just for those that were sick. Finally, just a word on risk communications, community engagement. This is not promotion, this is not messaging, this is understanding that it has to be timely and accurate, multimodal, culturally sensitive, the right person talking. It has to be two-way and involve the community. It has to address all the necessary languages. And this is a nice publication from Africa, which actually showed huge similarities in risk communication in community engagement strategies, which really suggested that either the sharing of information or protocols through WHO, IFRC, UNICEF and things like this were really working, because they were all so similar. This is one we put out about risk communications, community engagement in the foreign worker dormitories. It was just so hard communicating with 300,000 men that were in dense communities of different backgrounds, and we just weren't geared for this. So this describes this, and we've got another publication in press on risk communication and how to develop risk communication tools to develop products. So just going back, you'll remember this slide earlier on, and if I just abbreviate it by taking out a lot of the detail, and hopefully what I've shown you is that research really belongs in every pillar of outbreak response, and not to mention the preparedness aspect. So this is not to belittle the sort of more upstream work, whether it's drug discovery, in vitro work, animal studies, basic science. This all has to go on, but obviously it's not key operationally useful in the immediate sense. You'll remember I showed this picture early on as well, just to say that it is a cycle, and these are my concluding remarks about research and outbreaks, that the preparedness and readiness phases apply to research as much as they do to response. Getting your funding sources ready, getting your relationships in place maybe with funders, with WHO, whatever, the collaborations within your country and within the region, globally, your capacities to do the work that you'd like to do. Having, you don't want to spend 6 months getting ethics approval during an outbreak. So how can that be, the system be fast-tracked? The leadership and coordination, just as much as a response, it's critical in a research program, because that will enable all the work. I would ask people to think outside their traditional research areas, because there is so much that needs to be done, and it's really about looking at a particular question at the moment and say, do I have the capacity to answer that, or can I form collaborations that can answer that? And that's very much been my mantra through the outbreak. I think be opportunistic in that sense. It may not be something you've always wanted to do, but it needs to be done. Go and grab it, go and do it. That's what outbreak adaptation is all about. I think when in doubt, collaborate. And the number of people we've collaborated, whether it's nursing homes or the Ministry of Communications in Singapore, it's collaborators that I never would have thought of, but they've been important in the response, and therefore they're important in the research. And the other thing I'd say is just be aware of your capacities. If you've got potential to get into a global international clinical trial, then take that up. You do have capacities and power to have an impact globally, but if you feel that you don't, then for whatever reason, then the research applying what has been learned elsewhere to your own local context is still very important research to inform what's happening there, and it's still obviously very publishable. So with that, I can't see a clock, but I hope I haven't gone too long over.
It's fine, Professor. Yes, it's we leave time for like 10 minutes for Q&A. In case like someone want to ask you some particular questions, but like I like to open the floor for the Q&A. I have also a few questions actually in mind. I have to admit to you, Professor Dale, that before listening to this presentation, I thought that because you are from the medical science, right? I thought that you are going to focus on those. So I'm glad that you did on both sides, either on the medical or the sciences and technology and humanity, social sciences, all cover. And we see that the importance of research to respond to this outbreak. My first question is this. What is the lesson learned from the previous virus infection? Like we have the Ebola, we have the SARS from the past. How come for this COVID-19 this time, it takes us so long to get the vaccination, all those kind of things? What are the lessons learned from the previous one that we could apply to the current situation?
Well, there's a lot.
Yeah.
You know, I think, well, I guess if I go the highest level, the biggest lesson learned is the importance of research, which people regard, the public regards as science. And what they're saying to politicians is listen to the science. Now we're going one step up, and we're saying do the research so the politicians have that scientific information. and the whole point of, you know, I think when you say the vaccine went slowly, that's not what you'd hear from the average person on the street. I'd say it went so fast. Sure. Within a year, it's invented and all these trials are done, and we're jabbing people. And that was the source of a lot of hesitancy. Richard Hatchett believes that he can get that. He's the head of CEPI. He believes he can get that down to 100 days. Now, as we all know, we had a vaccine in January 2020, right? It was just that it hadn't been tested. So we had to do the animal studies, we had to do the phase 1 and the phase 2 trials, and then the larger phase 3 trials. We know with flu, we don't do that every 6 months or every year. We just accept that it's been modified. We don't have to go through the trials. We can go ahead. So he's going, you know, I think we've learned that the public, I think, can now accept a shorter lead time. But we also know that communications is critical. I mean, we could go through everything. In fact, we could go through all these. I'll just go back to this one. You know, we could go through the drug discovery. We could go through the logistics of getting it out to people, the distribution. So one of the lessons learned is in terms of distribution is don't put all the factories in rich countries, especially rich big countries. And Singapore has been approached to produce to be a regional hub for vaccine manufacturing, because we've only got 5.5 million people. So we're not going to be, you know, the US that says, well, let's vaccinate our 250 million people first, times 2, before we give it to another country. Now, it wasn't that black and white. They still gave out quite a lot, but a small country with strong technology in a region with high demand, that's where they should be being manufactured. So logistics was shown. Communications, it is huge. If people don't believe you, or people don't have the information, or you're letting the misinformation get ahead of you. So again, risk communications, community engagement is critical. So yeah, I could go on a lot about lessons in anything actually, but it always comes down to these pillars, I think.
Thank you. I think communication is also very important. I totally agree with that. And we have learned quite a great deal from this COVID-19 infection. But, you know, for the communication in Thailand, let's say, and I think this could be the case for the other countries as well. But hear me out here. Because in Thailand, we still have the discussion like whether to get vaccinated or not to get vaccinated. You know, like kind of the communication from the public health agency or from the governments to the citizen is not so so clear, or it's the citizens have little confidence. That's why we have that argument. It's that some people hesitate to get vaccinated. You know, but what is the case in your view? What is this case in your view? And what's the kind of the situation in other countries, if you have the information to share?
Well, I can generalize by saying it's different in every country, but it comes down to that the slide, this one on RCCE, which is community engagement. If you don't so we look at two ways. If we don't understand, if we're not hearing the people, then we're not then we can't message properly. If we don't understand the concerns, and that also has to be dissected out. If we don't understand that, for instance, Muslims are concerned whether the vaccine's halal, and therefore Singapore would go to the Mufti in Singapore. And he did a lot of work to, you know, in the media and in social media and various forms to reassure the Muslim community that it was safe. If I go on television and say to the Muslim community it's safe, it's completely invalid. So that's this right messenger sort of thing. So risk communications, community engagement is really a social science. The social science group should take it up, but it's how you implement it. It's not just about messaging. It's how do you use your prime minister? How do you use your minister? How do you use your academics? How do you use your comedians and television personalities? They've all got a role in delivering the message once you understand. We realized that as did Hong Kong and China, that there was a lot of hesitancy in senior Chinese people. It was extraordinary because in the West it was the younger people that were hesitant. But there's I think Chinese above 70 in China is like, no, above 80 has a vaccination rate of 52%. Now they're the ones that are most likely to benefit from it. And when we realized this, we did a lot of surveys, KAP surveys, to understand what the deal was. And we ended up with like 4 issues, and that became part of our messaging back to them. One was, we'll wait. We don't want it now. We're not saying no, we're just saying we want to wait. And that was, you may have seen that very entertaining video from one of Singapore's comedians, and it was called Don't Wait, Don't Hesitate. And that was directly because we'd understood what the problem was. Now that had moderate success, of course. That's you have to do more than that. But a lot of people went door knocking and spent half an hour with unvaccinated seniors saying, please listen to me, I want to save your life. Forget the fact you've got heart disease and hypertension. So anyway, that's what risk communication, community engagement's all about.
Thank you. That's quite the same here in Thailand, the situation just you shared in China. Yeah, I like to have another question, you know, while if the participants also want to have the questions, they may like to put into the chat box here. But my question is this. from what we learned from the COVID-19 this year, even though you said that the vaccine launched in Jan 2020, that was quite quick, right? But here we have the situation. Anyhow, for
no, it wasn't launched in January 2020. It had been invented. But it hadn't been tested.
Go through the testing, right? The testing period. Okay. Yeah. Thank you. Then for this situation, what could we prepare ourselves for the next outbreaks? We believe that in the future we will have the next outbreaks. We just never know what it is, what it will be. But for that is that there are good breaking into the roles of the people if we are talking about the preparing ourselves, like for the public health agency, for the business entrepreneur, because this has been affected by the COVID-19 quite a lot, and also the citizen. Let me ask you for these three roles. One is on the public health agency, for the business owners or the entrepreneurs, and also for the normal citizen like myself.
Yeah. Are you normal?
But
you were special.
Thank you.
So the first thing that has to be done, if you remember those 4 yellow circles, is analyze how it went this time round. And you analyze it in this sort of modular way. How was our case management and our surge capacity and all these sort of things? How was our maintenance of other essential health services? How was our communications? How was our IPC? How was our logistics and our supply chain? And every country, for a start, must do that. You can't learn if you don't reflect. And countries that decide to just sit back and say, we did a good job, no one else could have done better, are missing the whole value of what could happen. So how to prepare needs to be defined by the review. Okay, so if your supply chains were fine because you're from a country that makes a lot of food and does a lot of exporting, then you could say, okay, well, that wasn't a problem with us. But other countries, for instance, Singapore, under constant threat from the supply chain because we import everything. So you need to look at it that way. But I think our community engagement was very strong. We don't have the same challenges of a lot of countries. We've got good trust in government. So that wasn't an issue for us, as opposed to in other countries where the right side of politics and the left side of politics had different approaches to vaccination, which is just madness. So I think preparation needs to be done by review, and that also reflects on businesses. So any business would need to reflect, how do we become resilient if this happens again? Travel businesses need to work out what's plan B if this happens again, because we only just survived this. How are we going to survive the next one? Or airlines, and maybe that's diversifying your work. I don't know. I'm not a businessman, but I do know if you don't reflect, you could argue, I hope our foreign worker dormitories evolve in Singapore so that doesn't happen again. I think the food preparation areas and abattoirs and all these types of places had a lot of outbreaks. And that's largely because they're metal and they're cooled and people are underpaid, so they came to work when they were sick. So they could all be looking at themselves and saying, okay, how do we do better so that if this happens again, we're not vulnerable, we're not a hotspot. Nursing homes, how do you make your nursing homes more resilient, rather than just having them go through and cause so much severe disease? I think for individual people, again, I'd stick with the same formula of just reflecting on how you did. whether it be your own physical health, because we know if you're like an overweight smoker or something, you're going to be at greater risk of an illness. So maybe it's just being healthier people, being a healthier population is going to make you more resilient. You know, maybe having a better understanding of science will help you engage more. Maybe, yeah, understanding the limitations of the political system in your particular country and how that works. I just think everyone and everything needs to have a big reflection on how they could have done better.
Thank you. That is very great wrap up for this presentation, Professor. We learned a great deal, and as a citizen, you know, I think we are educated from this disease. Okay, that's also emphasized on the role of the research as a core pillar as your presentation topic. That's very excellent. I'd like to thank you because I don't see the questions. Perhaps I asked all the questions already. And I'd like to thank you for this presentation. I believe that all the participants and including myself, we are very fortunate to have listened, and we get smarter and smarter from listening to your presentation. Thank you very, very much. I'd like